Да.
Good afternoon. Today's session is starting with someone who certainly needs very little introduction, Dr. Ismaili, who I must say many times has saved my patients with serious orbital disease. Pete is going to discuss with us life-threatening tumors during pregnancy. Pete.
Thank you very much, Jim. I appreciate your introduction. And this is a talk that I didn't get to give on Thursday during the confessional session because of my flight got delayed terribly. And so Luigi was kind enough to give me this time to present these two cases that have given me pause in retrospect. So I have no financial disclosures. These are my current affiliations. So this is, I have two cases, two patients. First one, a 33-year-old woman of African-American descent, heritage, who was referred to me for management of a recently biopsied conjunctival melanoma. The clinical photo you see here is after the biopsy, so obviously either was an incomplete excisional biopsy or she truly has multifocal disease, which can happen. And as her course unfolded, I actually believe that she likely has multifocal conjunctival melanoma, which is a usually aggressive form of conjunctival melanoma. And you can sort of see it's near the punctum and upper eyelid, and sort of approaching the fornix location. And although we couldn't tell the tumor thickness on the biopsy because of tangential cutting, it looked like it was at least 1 millimeter thick. And at the time of this presentation, importantly, she was 16 weeks pregnant. And this is the challenge this is the reason I'm presenting this confessional case. So you can see the areas of abnormal pigment that are presumed to be residual melanoma or multifocal or otherwise residual. And we couldn't palpate any lymph nodes. We did do an ultrasound of the regional lymph nodes because that doesn't involve any radiation, so the patient was comfortable with an ultrasound as part of her management. That was done. It did not show any metastasis in the regional lymph nodes. So again, she's 16 weeks pregnant. The recommendation from if she weren't pregnant, our standard recommendation for her would be wide local excision of all the areas of residual melanoma with the plan to do sentinel lymph node biopsy, likely at the same time. And for systemic workup, because we have to make sure she doesn't have metastasis, we would do CT of chest, abdomen, and pelvis with contrast, and we would get an MRI of the brain. This was discussed with her, as well as with her husband, as well as with her obstetrician at the time. And after much deliberation by all of us, she, being the sweet, wonderful mom that she was, she elected to go to term without any interventions in the interim. She did not want to have any form of workup or surgery during pregnancy. So we elected to then do very careful monitoring of the conjunctival lesions, as well as hold off on systemic workup because she did not want any exposure to her baby. So every 2 months, I saw her for clinical exams. she had an uneventful delivery of a very beautiful, healthy baby boy. But just before, and our plan was to 1 month after delivery to take her to surgery and do all the things that I mentioned. But before going to surgery, we wanted to repeat the ultrasound of the lymph nodes to be sure that they're still okay. And lo and behold, she had a new bright parotid nodule. And on final aspiration, it showed metastatic melanoma, unfortunately. So the patient did go to surgery, had wide excision of the conjunctival lesions, had cryotherapy, had a right parotidectomy, neck dissection, followed by radiation therapy to the lymph nodes. She was also treated with adjuvant PD-1 inhibitor, immune checkpoint inhibitor, nivolumab, with hopes that this would prolong her life and prolong her disease-free survival, since she already had lymph node metastasis. She also had some topical mitomycin C. And we continued with our monitoring every 3 months. 10 months after surgery, she had a CT of chest that showed new lung nodules. This was despite the PD-1 inhibitor, nivo, so we added a second immune checkpoint inhibitor, ipilimumab, to improve our chances. 8 months later, the pulmonary nodules continued to enlarge. Eventually, they were large enough to be biopsied. It was metastatic melanoma, unfortunately. She had stereotactic radiation to the lung metastatic lesions. She was enrolled in a phase 1 trial, got some additional drug therapy. Her lesions continued to slowly grow. She was switched to targeted BRAF therapy. Her liver and lung mets responded. But unfortunately, 3 months later, she got brain mets. She got additional drug therapy was planned for her, but unfortunately, she progressed very quickly and passed away. This was 3 years from the initial presentation at 16 weeks of pregnancy, and her baby boy was 2 years when she passed away. So before we go into this case, obviously, when I was asked to participate in the confessional, the idea was that we would be judged. And I looked back to see, okay, what has been bothering my soul? I think I have lost many cancer patients over the years. She's not the first one. But I sort of felt that our decisions and recommendations perhaps influenced her decision. And it has, my conscience is bothered by that outcome. To this day, that's a patient that was treated many years ago. So now I'm going to show you a counter patient and another patient, 30-year-old woman, 31 weeks pregnant. She has a history of breast cancer, treated without any mets so far. She presents with this picture with with a frontal calvarium mass that is extending into the superior orbit. I biopsied through the eyelid crease incision. It was metastatic breast cancer, strongly HER2 positive, which is good in terms of drug therapy because it gives us an option to do targeted therapy against HER2, and combination of antibody drug combination, Kadcyla was recommended, possibly with additional surgery and radiation. Again, our patient elected to delay this until after delivery, which I think as a mother, I can relate to these decisions by patients. But again, my conscience bothers me because we went along with it, and I think how we present choices to patients probably influence outcomes. This is a photo she shared with me just prior to delivery. So, nervously, anxiously monitoring and watching her until term, it really is very anxiety-provoking because the lesion was growing, and this is her brain. So this is the photo just before delivery. And the good news is that right after delivery, she started to have the drug that I mentioned. It's called Kadcyla. It's a drug antibody conjugate, and it targets HER2. And her tumor, luckily, was strongly HER2 positive, so she had a remarkable response to this drug. And then she had some palliative radiation eventually to the orbit and brain. And our neurosurgery colleagues did do some cleanup surgery in the brain area. So she had a happy ending. Her baby was fine too. So my confessional for the other day, the session had that context, and I know I'm presenting out of context, but the dilemma for me has been and remains, what is the appropriate management of an aggressive, potentially life-threatening cancer when diagnosed close to the first trimester, which is what the patient case 1 had that challenge for us. And did we, I think my confessional was that I do feel guilty to this day about whatever role I played in advocating for the baby rather than the mom, and which is the correct choice. I don't have a good answer, but anyway, if I had to confess about something in my career, I would say this one bothers me. And, but our case 2 had a happy ending. But in retrospect, I'm not sure if we were just lucky, right? She could have gone the other way too, just didn't. Thank you.
Are there any questions for Dr. Ismaili?
Or rather comments too, if you have similar experiences, share them. It's Jose Montes here. He was supposed to. He was going to roast me that day.
I was going to say that Jose Raul is not here, but I'm sure that he will call you not guilty. I mean, so difficult. I was thinking, that boy will always thank his mother. I mean, she gave her life for him. Very, very different ways.
Yeah. Well, thank you. Thank you for that. But the little baby boy grows up without a mom too. You know, there's so many ethical issues around it. And really the case, I don't mean to make it sad, although it does sadden me. But I think Luigi wanted us to bring out the ethical dilemmas. And for me, it has remained a dilemma. But yeah, I think we do more good than bad in life, in our professions.
I have to say that I'm very glad that you finally gave this session, and that for those that were not at the confessional, it was one of the best meetings that I've ever been. So thank you, Luigi, for making it possible. Okay.
Well, I'm going to ask the famous Jose Luis to introduce himself. Take it away.
Thank you, Jim. Okay. I'm going to talk, it's a totally different topic. This is the place that I work at. I used to be the director of this department until May, June of the last year, after almost 22 years. And these are my colleagues, most of them are here, and it's my pleasure to be here in Italy back again and see a lot of ex-fellows and friends getting together here. I'm not gonna say a word about lacrimal gland tumors in front of Vita, but I just want to mention that in this big study, prolapsed lacrimal gland was number 3 in the list of pathologies of bilateral lacrimal gland disease. And I love to do this talk because we really talk very few about prolapsed lacrimal gland. I'm not going to talk about anatomy, just to say that in order for the lacrimal gland to be in the right position, there has to be a very good orbicularis muscle tone, a good orbital septum, and good ligamentary system. There's a ligament called Sommering ligament that is the one that holds the lacrimal gland in position. When some of these factors fail, then the lacrimal gland descends, and this is something that we have to think about and look for it. There are many, not that many, but some reasons that can lead to a lacrimal gland prolapse. Congenital disease, trauma cases, thyroid disease, and inflammatory. But probably the first etiology that was meant that mentioned lacrimal gland prolapse was blepharocheilitis syndrome, and you know about this. But what I'm going to talk about is the spontaneous prolapse of the lacrimal gland. And it is usually associated with other periocular factors. And the first case was described in 1895, so it's almost a century and a half. We're getting old. And it is usually a bilateral disease, more common in women, and I'm sure that at some point, although a lot of papers mention aging, I believe that it has to be with congenital or genetic predisposition. This is, you know this, all these things much better than me, but there are two very important tests that we have to do. And I always tell my fellows, the eyes do not see what the brain doesn't know. If you don't look for this, you're not going to find it, and you're going to make a mistake in your diagnosis. And the two most common tests are just very easy. If you're going to do a blepharoplasty patient, just raise the eyelid, and you're going to find the lacrimal gland there. And in those patients that have like a passive lacrimal gland prolapse, the recommended test is to put them in supine position and do the same maneuver. If you want to have a test, CT scan is very easy. You can see the lacrimal gland prolapse there. And I love this picture. This is a patient that was referred for me because he had an herniated fat bud in the conjunctiva. And you can see, this is very important, especially for young people. See the difference between the lacrimal gland and the fat. What we cannot do, a lot of people, and Jose Raul mentioned that before, yesterday, a lot of people are doing blepharoplasties, but no one can do a better blepharoplasty than us. And it is not a good result if instead of removing fat, we remove the lacrimal gland. We need to know about anatomy. And the other differential diagnosis is dermolipoma. I'm not going to talk about all the pathologies that Vita usually sees. And this is very important. Guy Mathry, in a recent paper, he said that almost in 60% of his blepharoplasty, he finds some amount of lacrimal gland prolapse. I know that we all do upper blepharoplasty, so we have to be aware of that. I believe that Mathry's numbers are far away from mine, but well, this is something that we have to take in control. So, once again, we have to think about it, and we have to look, and when we're doing a preoperative evaluation of a patient coming for a blepharoplasty, we have to check visual acuity, tear system, the ocular surface, everything that you know. But try again to see if the patient complains of some bulging in the lateral area, think about the lacrimal gland. And you can see it in the open position, but also if you ask them to close their eyes, it's very easy to find it. This is not fat. And you have to tell the patient that is not fat, and the problem is the lacrimal gland prolapse. Again, Guy Mathry made a classification, mild, moderate, and severe degree of lacrimal gland. So what do we do? Some people say do nothing, and probably we can have dry eye. Can I raise your hand who does nothing with lacrimal gland prolapse? No one? Resection, who resects the lacrimal gland? Good. And reinsertion? All of you, yeah. Great. So this is what I do. If I see either preoperative or transoperative, I like to suspend it. And this is the way that I do. It's a normal blepharoplasty surgery. This is the way that, not in all cases, we remove fat. But I brought this to you because if you are in the correct level, if you're in the correct position, you're going to find out this is fat. And the fat is different than the lacrimal gland. The color is different. There is a lacrimal gland. And once you free all the tissue around the lacrimal gland, you're going to find it out. And then we have to bring it back to its origin, and we know about anatomy. See, this is a beautiful dissection. Behind it, it's the levator muscle. So what I do is just to open the roof of the periosteum in the roof of the orbit, and we're going to place it back right where it is. I used to use Vicryl. Now I'm using 5-oil-proline or 6-oil-proline. Sometimes one stitch like this is enough. Sometimes you need to do two. What I've seen is that postoperative patients, after blepharoplasty, takes a little bit longer for inflammation to go up. But you can see 6 months after. And this is something that Jose Raul said yesterday, and I believe that where we are is the best place to be. She only had upper lid blepharoplasty. You can see the amazing change in her face only by doing upper lid blepharoplasty and lacrimal gland resuspension. This is 1 year after. 5 years after, 2.5 years after, and some years ago, 12 years ago, one of our fellows did a thesis, and she found no complications. We didn't have a reoperation in patients after 2 years. And this is very important. No reports of dry eye. And I have to tell that probably we should now start looking more to dry eye symptoms. Everything we do has to do with the eye. We're ophthalmologists first. And we should point out some more attention to the ocular surface. So, as I said, we usually talk very, very little about this pathology. It happens very often. And for my surprise, when I was doing this talk, if you look in PubMed, for dacryoadenopexy, which is the suspension of the lacrimal gland, there are only 4 articles. When you look for dry eye and this surgery, no articles. And when you look for complications of this surgery, no articles. So even though that we see this pathology very often, very little is written about it. So in my conclusion, I can tell that in more than 2,000 surgeries that I've done in my almost 25 years, less than 12% need to have a lacrimal gland suspension. And once again, my take-home message is if you don't look for it, you're going to miss it. Eyes do not see what the brain, what brain doesn't know, okay? And this is 12 years after. And I'm not going to do any talks, any comments about Danielle, because it's not my job here. But I just want to congratulate you, Luigi. This is our last meeting here, 10 years ago. And you can see that the amount of people that he brought this year, it's almost triple, quadruple. I don't know, Luigi, but congratulations. I really hope that you keep on going with this. And these are my friends, the ones that started Stop and Up, and Daniel was one part of it. And these are my 2 mentors, Daniel and my father, and I'm so glad that in life we could make an homage ceremony for them. I'm going to miss it. Que grande que sos, Daniel! And he's the only one that ever called me El Chino. So, only for him I'm going to be El Chino. I know why. Thank you very much.
Thank you very much. Hi to everybody who's still here. So we're going to talk about punctal stenosis and some new approaches that we can give to this problem. So we remember what we call lacrimal stenosis. It's the narrowing or occlusion of the lacrimal punctum. It affects 17.3% of the adults, and it's more frequent in women. The inferior puncta is the one more affected, but it can be bilateral in 60 to 67% of the cases. So the primary causes are chronic blepharitis in 40.5%, which is something that we have to look every time that we see this kind of patient. 27% we can't really know what's happening. Eyelid malpositions take a role in this also. And as secondary causes, we can find topical medications in 75%, which is a high percentage. There are some medications for glaucoma which are really involved, and there's a new study about netazurdil, which is an anti-glaucomatose drug, which has seen to really cause this problem, and when you suspend it, it's reversible. You can treat the problem just suspending the medication. Also, we can see involvement in chemotherapy, sarcoidosis, and autoimmune diseases like pemphigoid, but it has more additional things that we can see. In the clinical presentation, a prefer, of course, but we have to look for canalicular stenosis also, because we can find it at a high degree. As a diagnosis, it's mostly clinical. We can see it at the slit lamp examination, where we have to look for problems at the punctum, like the double punctum, or if we have a papilloma. Then we just put a drop of dye, and we can see if it's functioning or not. Probing and irrigation are important because of the canalicular stenosis combination, and OCT has played a role in the last few years. There are some other advanced diagnosis imaging, but they're really used more for research purposes. About medical management, it's the first line for mild cases. Stop causative medications is very important. The treatment of the underlying conditions as blepharitis is also very important, because if you're going to treat the stenosis but you can't stop the cause, you're going to fail. Topical steroids have an involvement in this topic, but what is most effective is cyclosporine, and it has a functional success of 69%. And if you combine it with punctoplasty, it's even higher, about 88%. So other things that we can do to manage it are the non-incisional surgical approaches, such as the punctal dilation with a stent. For example, the perforated punctum plug is a very nice procedure. We can do it at the office. We don't need to get the patient to the OR, and it has a good success rate. The stent duration, you need to leave it on for about 2 to 6 weeks, and it has about an 8% restenosis rate. If we're talking about mini monoca is also very effective, and it adds up that it also treats canalicular problems. If we're talking about surgical approaches, the 3-snip punctoplasty has an 84% success, and there are also another surgical approaches, but none of this has demonstrated to be superior one from another. So there are many studies studying incisional versus non-incisional, and in these studies we've seen that the trend is towards non-incisional, because we can achieve similar outcomes, because there's lower restenosis with these techniques, and if we can achieve similar outcomes and preserve an anatomy and the lacrimal pump function, it's a little bit better. So my conclusion would be,
We need to treat underlying conditions. It's very important so that we can succeed in our treatments. The medical management is very effective in mild cases. The 3-snip punctoplasty improves the quality of life of patients, and in the studies it says that it's more effective in this parameter. And the trend is towards non-incisional techniques because they show equivalent success preserving the anatomy and the lacrimal pump. These are my references, and thank you so much.
Thank you, Dr. Evans. Next up is Dr. Basel's lacrimal sac tumors.
Good afternoon, everybody. I'm going to speak in Spanish. This is going to be easier, I guess, for the translation. I'm Dr. Rosa Balcells. I'm the past president of the Chilean Society of Ophthalmology, Spanish. Y actualmente trabajo en Cincinnati, en el Cincinnati Eye Institute. Y les hablo de la presidencia de la Sociedad Chilena porque la verdad es que este tema tiene un enfoque un poquito gremial. Antes de comenzar, quiero agradecer a Luigi. Esta es una de las tantas fotos que se han mostrado ya, ¿cierto?, del curso anterior, que fue inolvidable y que hace que muchos de nosotros estemos aquí de vuelta, ¿cierto? Bueno, y les decía que tiene un enfoque un poquito gremial porque durante mi época en la presidencia de la sociedad me tocó ver algunas cosas que me llamaron mucho la atención. En oculoplástica había una migración muy importante hacia lo estético. Y eso ha hecho que desde el punto de vista operativo tengamos cada vez menos colegas en los hospitales realizando cirugía funcional. En mi país, en Chile, eso ha significado que hay una lista de espera para datriosistorrinostomía que es eterna y que desafortunadamente, como no tiene un apoyo gubernamental, ha pasado a segundo plano cuando se ponen comparado con las otras patologías oftalmológicas como desprendimientos de retina, obviamente, y cataratas. Por lo tanto, hoy en día tenemos una población muy grande con problemas de la vía lagrimal no resuelta. Y eso ha hecho que muchos colegas, no oculoplásticos, sino médicos oftalmólogos, empiecen a aventurarse más en la datriosistorrinostomía. Y empezaron a llegar algunos casos, 2 específicamente, de demandas por haber realizado datriosistorrinostomías en pacientes que finalmente tenían tumores y que eso implicó un mal tratamiento de estos casos. Entonces, frente a eso, yo me puse a pensar y dije, ¿cuál es la mejor estrategia para pesquisar esos tumores? Especialmente pensando en que no todos los médicos que están realizando las datriosistorrinostomías tienen altísima experiencia en estos procedimientos. Entonces, para hablar un poquito de tumores y ponernos en contexto, este es el típico esquema que le mostramos 1 y 1000 veces a todos los residentes, pero yo lo muestro porque quiero recordarles cómo va cambiando el epitelio de la vía lagrimal a medida que vamos avanzando, ¿no? Y tenemos los canalículos que tienen un epitelio estratificado, no queratinizado, con una capa basal que está compuesta de fibras, y luego pasa al saco lagrimal en donde el epitelio cambia a un epitelio cuboideo y empiezan a aparecer algunos elementos de epitelio respiratorio, algunas células caliciformes, y la capa basal se transforma en algo más adenoideo donde se encuentran algunos linfocitos. Y luego pasamos al conducto nasolagrimal, que ya aparece, ¿cierto?, un epitelio respiratorio con células ciliadas y con mayor número de células caliciformes. Entonces eso es importante para entender de dónde salen estas neoplasias. Y les voy a mostrar, yo me puse a revisar los casos míos de tumores de saco lagrimal y voy a mostrar 3 casos. Rapidito, este es un hombre de 60 años que el único antecedente es diabetes y que consulta porque tiene una historia de epífora de 2 años de evolución, que además tiene un aumento de volumen en el saco lagrimal. Un caso bastante simple para nosotros, llama la atención el aumento de volumen y el examen clínico es el típico examen clínico de un paciente con epífora y con este aumento de volumen de consistencia gomosa, indoloro en el área del saco lagrimal. Se le pidió se le hace una hipótesis diagnóstica de un mucocele, eventualmente un dacrocele o un tumor, ¿cierto? Y se pidió una tomografía que solamente se las voy a mostrar ahora, mostraba esta masa. Y se decide hacer una dacriocistorrinostomía con un drenaje versus una resección del tumor si se trataba de un tumor más sólido y no de un dacriocele. Esta es la imagen. Como se ve, es una masa que no está erosionando hueso y que está bastante bien localizada a nivel del saco lagrimal. Se hace la cirugía y se logra resecar una masa completa junto con el saco lagrimal que sale bastante bien, bastante fácil. De hecho, estaba amoldándose hacia el conducto nasolagrimal y se decide no realizar la dacriocistorrinostomía, sino solamente dejar una intubación que pasaba perfectamente hacia la nariz. Y esta es la imagen de la histológica de esta masa que fue resecada. Y aquí lo interesante, aquí lo interesante que ustedes pueden ver, este es el saco lagrimal, en donde se ve perfectamente la pared con este epitelio cuboideo estratificado que les decía, y cómo aparece esta masa, ¿cierto?, que tiene estas indentaciones exofíticas y endofíticas bastante grandes. Aquí se ve con mayor aumento cómo se diferencia, ahí se ve la flecha sobre el epitelio normal de todo este epitelio estratificado, papiliforme, que tiene la masa. Y es muy linda esta imagen porque uno ve perfectamente dónde se produce la transición a este tumor. Hay un close-up ahora con 40X de la transición al tumor, donde se ve este epitelio que, para ser un epitelio tumoral, es bastante organizado, bastante estratificado. Y el reporte citológico de este tumor fue un papiloma escamoso con una displasia intraepitelial de bajo y alto grado. Este paciente se fue a tratamiento y esto son sus resonancias magnéticas de controles posteriores, no ha tenido ninguna complicación ni ningún problema. Luego viene otro caso clínico, que es una niña de 11 años, que su motivo de consulta es una epífora solo de 10 días de evolución, que además se agregó un sangrado por el punto lagrimal a los 4 días. Y esta es la foto que trae la mamá, obviamente súper preocupada. Entonces se le pide un escáner y lo que se muestra, las imágenes, ustedes pueden ver esta pequeña masa ahí a nivel del saco lagrimal, ¿no? Y se decide hacer una resección con biopsia rápida. En la biopsia rápida, el informe oral refirió un tumor fusicelular de bajo grado con un diagnóstico prescintivo de mangioperisitoma o un tumor fibroso solitario, lo que hizo que se decidiera resecar completamente el saco lagrimal con la masa y afortunadamente resultó en la biopsia diferida ser un hemangioma capilar lobulado, por lo tanto algo benigno. La niña tuvo que ir a una reconstrucción de vía lagrimal para lidiar con la epífora. Entonces, estos dos casos que le acabo de presentar son casos bastante es difícil que a nosotros se nos pasen, o incluso a un colega oftalmólogo, porque son casos que están fuera del estándar de la obstrucción de vía lagrimal. Pero ahora les voy a presentar un tercer caso, que es una mujer de 78 años, que tiene una fibrosis pulmonar, que usa esos medicamentos y que tiene una historia de epífora que lo único raro es que su epífora es intermitente. Tiene 2 años de evolución, no ha hecho dacrocistitis y había sido evaluada unos años antes. Pero más allá de eso es el cuadro clásico que nosotros vemos de una paciente con obstrucción lagrimal. Su examen era normal, con un tear lake aumentado y una irrigación con un reflujo al 100%, lo que significa para probablemente la mayoría del auditorio una obstrucción de la vía lagrimal común y corriente. Se le hizo un escáner y el escáner solamente mostraba un saco lagrimal dilatado y se programó hacer una dacriocistorrinostomía. Durante la cirugía se decidió tomar una biopsia de la pared del saco lagrimal porque a mí me pareció que el aspecto del saco lagrimal no era el típico y se manda a biopsia. Y en la biopsia aparece esto, que fue una sorpresa, ¿cierto? Un tejido fibroconectivo infiltrado por un carcinoma sólido poco diferenciado. Estas son las imágenes y si ustedes las comparan con el anterior, que era bastante diferenciado, se ve solamente un tejido fibroadiposo con estas células, este tumor sólido infiltrando todo. Y aquí llama la atención, empieza a verse un poquito más organizado, tiene como lo que dice el patólogo, un hábito basaloide, porque empieza a parecerse un poquito como un carcinoma vasocelular, y ahí se ve de nuevo que tiene como estas empalizadas parecidas al carcinoma vasocelular donde están las flechas. Se le hizo una tinción de inmunistoquímica y el diagnóstico histopatológico refirió que esto era un carcinoma de células basaloides. El carcinoma de células basaloides es un tumor raro de glándulas salivales que está muy rara vez descrito en saco lagrimal. y dependiendo del grado de malignidad va a depender el tratamiento. Esta paciente se fue a una resección con maxilofacial completa y con radioterapia. Entonces, ¿por qué les quiero contar esto? Porque cuando yo hice el fellow en Cincinnati, había el hábito de tomar biopsias a todos los sacos lagrimales. Y cuando uno se va a la literatura, se da cuenta que es bastante ineficiente tomarle biopsia a todos los sacos lagrimales. Porque si uno ve todos los reportes que hay, ninguno es mayor al 3% de positividad. Y cuando hablamos del 3% de positividad, incluimos algunos diagnósticos inflamatorios que aumentan un poquitito ese número. Por lo tanto, la mayoría de las biopsias van a salir inflamación crónica, fibrosis o incluso nada. Pero la pregunta es, ¿cómo logramos pesquisar estos pacientes y que no se nos pasen? ¿Vale igual la pena? Y aquí hay un trabajo muy interesante que les quería mostrar, que es una revisión de la literatura donde muestra el diagnóstico etiológico de las distintas series que han hecho estas biopsias permanentes en los sacos lagrimales. Y llama la atención algo que a mí me parece que es muy llamativo, ¿no? Y es que, si bien el número que aquí no está, pero el número absoluto, como les decía, es menos del 3%, lo que quiero que se fijen es en la lista de los tumores benignos o malignos. Los epiteliales son los más comunes, y como les mostraba, probablemente tiene que ver por lo del epitelio, por el tipo de patología. Pero fíjense, cuando uno ve los benignos en epiteliales, la suma completa abajo son solo el 20%. Y los tumores de saco lagrimal, los malignos de epiteliales, pasan a ser el 50%. En todas estas series, donde se hizo biopsias aleatorias, lo que salió positivo era maligno, mucho mayor que benigno. Lo mismo los mesenquimales, y bueno, los linfoides y melanoma, que es más raro aún, pero no queremos que se nos escape. Entonces, frente a esto, yo dejo abierta la pregunta. No sé si es la mejor opción, pero creo que hay que pensar que si bien uno puede tener siempre biopsias negativas, el día que tenga positiva le puede salvar la vida a algún paciente. Entonces, en resumen, solamente hay que pensar que si bien son raros los tumores de saco lagrimal y que la sintomatología es inespecífica, pero que la mayoría de ellos van a ser malignos y por lo tanto tenemos que pensar en cómo vamos a estar preparados para que no se nos pasen a nosotros o a los que estén haciendo las dacriotiroinostomías. Y bueno, como todos hemos hablado ya mucho aquí, Daniel fue un gran amigo, un gran mentor, y le mando un beso al cielo porque se le extraña enormemente. Muchas gracias.
Thank you, Dr. Marcel. And now, Dr. Merritt, we have problems with the connection with Dr. Melgen. So, Dr. Merritt.
Thank you. So you're in clinic in the afternoon, and you look on your schedule, and the next patient was referred with a spastic entropium. You go into the room, introduce yourself, look at the patient, pull down the lower eyelid, and lo and behold, the referring doctor missed the conjunctival scarring causing the cicatricial entropium and trichiasis. The challenge is trichiasis, treating it secondary to cicatrizing conjunctivitis. And I must say that in this presentation, there's very few surgical solutions that are original. We borrow from the past. And this is certainly the case with this presentation. In a chance conversation 20 years ago, an Egyptian ophthalmologist commented to me, I quote, "I can cure trichiasis from trachoma in 5 minutes. I split the lid and insert a normal mucosal graft." Well, that got me to thinking about surgical solutions for cicatricial entropium. And today's presentation is a refinement of that technique recommended to me 20 years ago. I'm pleased to tell you that I'm honored to practice with Jorge Corona, my daughter, Helen Merritt, and our newest associate, Tiffany Ho, in our oculoplastic practice in Dallas, Texas. Now, the causes of cicatricial entropium in our practice, most commonly it's cicatrizing conjunctivitis, followed by a few cases of trachoma, a few cases of Stevens-Johnson syndrome, trauma, and then some physician-caused cases of misdirected lashes. Examples here are patients I'll demonstrate with today: Stevens-Johnson syndrome, trachoma, cicatrizing conjunctivitis, and even a congenital case of anophthalmia. Now, traditional surgeries are tarsal fracture, cryotherapy, and lid and lash excision. However, a better solution, I believe, is to simply incise the lid margin posterior to the trichiasis in the gray line, and then split the tarsus for about 3 millimeters. Now, this approach has an advantage in that it does not violate the conjunctiva, so it avoids insulting tissues where cicatrizing forces may be at play. We then wedge an oral mucosal graft into that split eyelid margin, and this has a doorstop effect, rotating or maintaining the rotation of the anterior lamella and the misdirected lashes forward. Now, here's an example: a patient with trachoma. You can see her Herbert's pits. Now, she's lived in the U.S. for 20 years, and certainly her insults from chlamydia were in childhood. She's certainly not infected now, but she does have the misdirected lashes of trachoma. So here is splitting the lid margin very carefully in back of the misdirected lashes and dissecting into the tarsus about 3 millimeters. And then harvesting an oral mucosal graft. I prefer to do this with regional anesthesia. It's much easier to approach that oral mucosa and not have to work around a endotracheal tube or an LMA. That graft is thinned, and then it's thinned on the edges and trimmed to the size of the defect in the lid margin, and then sewn into place as depicted here, with horizontal mattress sutures holding the graft into position. You want to be careful and not have these sutures so tight that they distort the lid, and yet not so loose that they irritate the ocular surface. And here you see the patient post-op 1 week, post-op 2 weeks, and then post-op 2 years with a resolution of her misdirected lashes. Now, with cicatrizing conjunctivitis, which is difficult to prove on biopsy, but most commonly due to ocular cicatricial pemphigoid, we must induce remission medically for about 2 years before proceeding with surgery. These are the agents that we prefer to use, and that's for another discussion. But once you do induce remission, then one can apply the same technique. Now, why am I showing you a patient with thyroid eyelid retraction? Well, for 2 reasons. He not only has thyroid eyelid retraction, but he also has entropia of his lower eyelids, secondary to cicatrizing conjunctivitis. So Joe here had 2 autoimmune diseases. And once we induced remission with cell sapper for his cicatrizing conjunctivitis, in a combined surgery, we applied the Shore technique of upper eyelid lengthening, recessing levator, recessing Mueller's muscle, cutting the lateral horn of the levator, and doing a, so to speak, reverse ptosis procedure. And once the desired elevation or lowering of the lid was achieved, we put Joe a little deeper, harvested his mucosa, split his lid, sewed the grafts into the lid. And here you see Joe at 1 week postoperative, 2 weeks postoperative, and 2 years postoperative, with a nice inset of these mucosal grafts. This gentleman had sustained Stevens-Johnson syndrome and showed up in my clinic with his upper eyelid lashes pulled out. So again, you see we've split his lid margin, we've inset the oral mucosal graft, and here he is 2.5 years postoperative, now not having to pull his upper eyelid are his lower eyelid lashes with a nice inset of his graft and release of the cicatricial entropium. Another case of Stephen Johnson. I prefer to either operate on one side or the lower lids or the upper eyelids. I've never operated on all four eyelids. I must say I've never had a graft fail. But certainly I think it's best to stage, if you have four lids, stage it as two procedures. And here you see this patient 3 years post-op. Now here was a challenging case of meibomian gland carcinoma, which I used a stage technique of first achieving frozen section clearance of the margins, and then I'm taking another entire periphery and looking at that permanently. So after 2 days, we felt the patient was tumor-free, reconstructed her upper eyelid by taking a contralateral tarsal graft from the left upper eyelid, creating a pedicle flap of remaining upper eyelid tissue on the right, covering that tarsal graft. And here you see the patient at 1 week post-op, and then 7 years post-op. And on that 7-year post-op visit, the anterior lamella of the reconstructed lid, the skin had rolled in slightly and was irritating her cornea. So here was another case where we could apply insetting an oral mucosal graft into her upper eyelid margin and relieving her irritation. A trauma-related crisis of the lateral right upper eyelid relieved with insetting an oral mucosal graft, as you see here. I must say I missed one lash right here, and it wasn't irritating the patient, so we didn't need to proceed with any further procedures. In a case of congenital anophthalmia, these patients are short of conjunctiva, so with the prosthesis in place, there was a gross lash misdirection, which was relieved again with mucosal grafting and setting into the upper and lower eyelids. Well, lid margin incision and graft wedge insertion are my preferred and proven methods of surgically addressing significant trichitis secondary to cicatricial conjunctivitis and cicatricial entropium. Thank you, Luigi. Thank you, Ramona.
Thank you, Dr. Mary. And now we have Dr. Melton with entropion and ptosis of upper eyelid eyelashes, supratarsal fixation, and tarsal strip. Hi, Feroce.
Luigi is not here. Oh, he's here.
Feroce? Dr. Mejen?
Vamos nosotros ahora, voy yo. Vamos.
¿Puedes hablar?
Hola, ¿me oye?
Sí. Adelante.
Hola, mis queridos, no sé si me están oyendo. Estamos aquí en República Dominicana y voy a compartir con ustedes algo que lo hago con mucha frecuencia, que me mandan muchos pacientes que tienen ptosis palpebral superior, pero sobre todo ptosis de los párpados con entropio que me está dañando la visión a muchos pacientes. Es similar al entropio superior simple. Las pestañas están desviadas hacia abajo debido a la lasitud del tejido que controla la posición del músculo ocular. Pero si el músculo ocular está desconectado, la lamela posterior y los ligamentos se desplazan y descienden y provocan que el margen de párpado gire hacia abajo. En los pacientes asiáticos está causado por el tejido graso que separa las dos lamelas e inhibe la conexión estable entre el músculo ocular y la lamela posterior. el músculo orbicular se desplaza y gira 90 grados hacia abajo, causando que las pestañas me estén dañando las córneas. Para corregirla hay que reparar la lasitud, pero sobre todo crear una conexión entre el tarso, la aponeurosis, el músculo orbicular, que es lo que produzca la posición del músculo y de las pestañas. La técnica que yo hago es fijación supratarsal, en inglés se llama supratarsal fixation, fractura tarsal, que es abrir el tarso por la mitad completamente, y tarsal strip o tira tarsal. Le voy a enseñar un video de lo que yo hago, que es un video donde está la cirugía completamente del paciente. Esta es la paciente que ya la habían operado varias veces. Si ustedes se fijan, tiene ya toda la parte de arriba del párpado que la habían operado, pero no habían podido arreglar lo que yo le hice. Y aquí les voy a enseñar la técnica que yo hago con estos pacientes. Fíjense cómo las córneas están dañadas completamente. Habría que hacerle también a ella un trasplante. Y aquí entonces comenzamos a hacer la cantotomía lateral completamente como si fuera un entropio del párpado inferior, pero vamos a hacer un entropio del párpado superior. Ahí nosotros hacemos completamente en el canto externo, abrimos, separamos completamente la porción superior de la vía lagrimal, del canto lateral, y luego cortamos que sean 2 milímetros de ese poquito tarso que hay ahí. Entonces agarramos un vitril, como si fuera igualito que los párpados inferiores el entropio, vamos a hacer lo mismo del párpado superior el entropio. Y después que tenemos ya este hilo completamente abierto, abrimos arriba, como si fuera que le vamos a hacer la cirugía de párpado en el mismo sitio donde a ella le habían hecho las cirugías anteriores. Con el bisturí lo abro y luego con el cauterio me voy completamente hacia el tarso, a donde comienzan con las pestañas. Y luego rompo el tarso en el medio y agarro la parte del músculo orbicular con la parte de atrás del tarso. Y eso me hace que se me levante la pestaña completamente. Esto lo hago a nivel externo, medio e interno. Pero lo importante es eso. Después que está abierto completamente el tarso por mitad, agarramos lo del músculo orbicular, pero lo ponemos por la parte de arriba del tarso para que me levante el párpado completamente. Y ahí les voy a enseñar ahora cómo lo hacemos también con el otro lado. Y miren cómo las pestañas completamente ya se levantan hacia arriba. De verdad que es algo rápido, sencillo, pero es increíble. Miren en este ojo sobre todo cómo se ve que los párpados que tienen completamente entonces la pestaña. Miren cómo levanta completamente las pestañas hacia arriba. Miren la pestaña como ya lo tiene, completamente en su posición, y luego ya lo que hacemos es en el tarso al lado, ponemos otra vez en todo lo que es el revuelo orbital, y miren cómo ya el párpado queda completamente en su sitio, acabada de hacer la cirugía. Miren la paciente ya justo postquirúrgica, ya la paciente a la semana. Miren los párpados como están completamente abiertos, y ya a esta niña se le pudo hacer la cirugía de córnea y está perfectamente bien. Pero por eso quise compartir con ustedes esto que para mí es muy importante, y de verdad los extraño muchísimo a ustedes, no poder estar allá. Los quiero mucho, he estado pendiente de todos ustedes y un placer poder estar con ustedes ahora. De verdad, muchas gracias, queridos.
Doctora Hidalgo Landeros, Palpebral Reconstruction.
Grazie mille Luigi per l'invito, per avermi considerato in questo evento. Sono molto contenta qui in Ravello. My presentation, please. Ok. My talk is about dual flap, dual graft, single state reconstruction for the giant upper eyelid defect. Large upper eyelid defect remain one of the greatest challenges in the pericular oncology. Traditional technique involves temporary visual occlusion, stage surgery, and delayed functional recovery. Why eyelid defect matter? Obviously, protection of the globe, blink mechanic, tear film stability, margin position, aesthetic symmetry, and obviously oncology safety. This technique is described for the reconstruction of the upper eyelid extensive defect, within this case medial canthus, using the concept the dual or double graft and double flap. Dual graft, in this case, one is contralateral tarsoconjunctival graft, and the other is contralateral dermatochalasis skin graft. And double flap is the glaberal flap, and the other is orbicularis muscle advancement flap. This is the first case motivated me to think about this technique. It's an 84-year-old woman with the left eye is the functional eye, and after consulting several colleagues and my WhatsApp group favorite is the Sopano group, Dr. Piñata told me about this technique. And private biopsy showed that Merkel cell carcinoma, systemic study was negative, and the idea to make one surgery and the possibility to restoring the palpebra is, for that, I use this technique. Merkel cell carcinoma measuring 2.2 by 2.4 centimeter. It is resected with, in this case, I resect with 5 millimeter oncological margin, and I make a margin intraoperative frozen section was negative, but the large, giant upper eyelid defect is limited. I made a first little tensile flap, but the important flap is the glaberal flap, created to cover medial canthus and medial upper eyelid, and sutured tissue sutured with biacrylic 50 and silk with the skin with silk 60. And contralateral upper eyelid is subverted, and tarsoconjunctival graft is performed. Is resected as widely as possible. In this case, 26 millimeter wide and by 6 millimeter high. And tarsoconjunctival graft is sutured to remain tarsus, remain glaberal flap and conjunctiva, restoring the posterior lamella. The auricularis muscle is released from the skin, advanced flap is created, and sutured with tarsus with biacrylic 70, but is restoring, recovering all the new posterior lamella with the auricularis. The skin graft is being prepared, the contralateral dermatochalasis, and the skin graft is sutured with silk 60. This is the post-op, immediately post-op. This is a 15 days post-op with the tissues were removed. This is the right side, 2 months after surgery, and the left side is 3 months after the surgery, but after brachytherapy, because I know say the lymph node was negative, a sentinel lymph node, but the oncological treatment used brachytherapy, and all the time used lubrication and also insulin eye drop, because it's a very good for surface and okay. This is the case 6 months after surgery. This is a video. It's possible to show the video? With very good mobile restoration, the protection of the globe, comfortable for the patient, happy patient, with the cornea is very, very good. For me, it's a very good result. This is the first case, this series made by Dr. Gabriel Piñata from Uruguay. And in our hospital, we make a serious case. Our colleague Juan Cristóbal Ormeño, ophthalmology fellow, presented this serious case of the last Chilean Ophthalmology Congress as winning with the best scientific work. In conclusion, dual graft concept was designed to provide structure support, tissue vascularity, and immediate eyelid opening in a single operation. This is a possibility to the giant over eyelid defect, in this case with canthal defect, but maybe more than advantage techniques, it is a quality life advantage because it's a possibility to restore it in one time the surgery. Thank you so much. Esto lo voy a decir en español porque es un poco más fácil, pero la foto que estaba ahí era con Daniel el 2010 cuando Grupo Sopanov hizo una peregrinación a Santiago de Compostela y Daniel de alguna forma nos guió mucho a todos nosotros. Se le extraña, era una persona excepcional. Las personas excepcionales salen del ordinario, te tocan de una forma como él lo hizo con muchos de nosotros. Así que solo agradecer que haya estado en nuestra vida y un bacho al cielo.
Okay, it's rapid fire time. 4 minutes each. First, Dr. Wasaka Kozmolska on chemical burns.
Good afternoon, everyone. Thank you for the opportunity to present in such beautiful event here. Today, I am gonna to focus on the reconstruction of cicatrical eyelid deformities following chemical burns. No conflict of interest. Why are those surgeries so challenging? Firstly, there is always unpredictable extent of scarring. So usually there is always more than we see initially. And secondly, we always are faced with distorted anatomy, combining eyelid lamellas. And this is the first case with severe cicatrical eyelid deformity, mostly with cicatrical entropion of both eyelids. And I would like to mention that the main concern here was the partial upper eyelid lost that caused severe lack of thalamus. So in surgical steps, I released the symblepharon and then performed the tarsal graft from contralateral side. And then with the lower eyelid, I performed bilamellar reconstruction with margin rotation and then mucosal graft. And this is the result. And second case with also severe entropion, cicatrical entropion. But here, trichiasis was the main concern. That's why I decided to split the upper eyelid, then to release the levator, and that's why I could perform anterior lamella recession with averting lashes with sutures. And this is the result. And the third case, also with severe cicatrical deformity, but with ectropion. And this case required staged procedure. The first stage, I performed the scar release and full skin thickness graft of the lower lid. And then after a few months, I performed the skin release of the medial canthus, also upper eyelid, and also lower eyelid, everything in order to close the eye. and this is the result. What are the most important messages from me in this presentation? Those cicatrical cases require individualized strategy. We have to know that the tissue that can be grafted is also limited, and we need to be prepared for repeated surgeries. And also I mentioned about the extent of cicatrical changes that are often underestimated preoperatively. And if I would pick the one message for you from this presentation, the message is that working with those reconstructions, we should more work with those scars rather than against them. And yesterday, Dr. Medel told that we hate our scars, of course, but here we really need to respect them, not to excise them, just incise, release, and reconstruct. Thank you very much.
Thank you. Dr. Tesorites, addressing eyelash grafting.
Good afternoon, I'm going to speak Italian. Una breve presentazione sul trapianto di ciglia. Dunque, l'amaderosi è una condizione multifattoriale per la quale si riconoscono diverse cause che avete qui elencate e vi presento alcuni casi clinici. Questo è il primo caso, come notate assenza di ciglia sia superiormente che inferiormente, è un caso di anoftalmo congenito. È stato fatto per lei, è stato effettuato sia un graft di mucosa più l'innesto di ciglia, dopodiché è stata ricreata, come potete vedere, la piega palpebrale e poi è stato utilizzato per dare un gusto all'innesto il bimatopros per 3 mesi. Questo è il video. Allora vi faccio notare come solitamente si sceglie la parte mediale centrale, che è quella dove c'è una maggiore abbondanza di ciglia. Per quanto riguarda l'orientamento del bisturi è importante orientarlo in maniera parallela alle ciglia, alle radici delle ciglia, per evitare di danneggiarle. Quindi si procede al prelievo dell'innesto. Prelevato l'innesto, vediamo un attimino di vedere questo. Diciamo che la tecnica dell'innesto non è una tecnica utilizzata in maniera molto diffusa. Come sapete ci sono varie soluzioni che possono essere farmacologiche, che possono essere anche di ciglia artificiali, micropigmentazione estetica, però insomma questa è una tecnica che noi utilizziamo di frequente, soprattutto in caso di trauma, quindi è una condizione che non sia reversibile. Quindi prelevato l'innesto, che ora vedete bene, si va ad incidere la zona interessata dall'amadarosi nel prossimo passaggio. Si inserisce l'innesto, per la chiusura si utilizza un nylon 6 zeri, si effettua una tarsografia e diciamo nella parte finale al termine bisogna fare attenzione a quello che è l'orientamento delle ciglia, perché bisogna evitare quella che potrebbe essere una complicanza, l'entropion, quindi è importante che le ciglia siano ben vertite al termine. Ok, possiamo andare avanti. Il risultato finale è questo. Questo invece è un caso in cui c'era molta fibrosi, quindi abbiamo utilizzato la tecnica della lipostruttura e ve l'ho messa in evidenza per appunto considerare il lipofilling prima dell'innesto in caso ci sia un tessuto particolarmente fibrotico, comunque danneggiato. Questo è un caso invece di ustione complicata, vedete non si riconosce il fornice, non ci sono ciglia né superiormente né inferiormente, chiaramente per lui a parte l'innesto è stata fatta anche un grafto mucoso per poter inserire la protesi e questo è il risultato finale. E infine, anche qui vedete non si riconoscono né ciglia né superiormente né inferiormente, questo è a distanza di anni dall'intervento e vertendo la palpebra notate il buon orientamento delle ciglia. Vi faccio notare che comunque l'innesto di ciglia è soggetto a crescita, per cui vanno poi tagliate di tanto in tanto. Vi ricordo l'appuntamento a Parigi il 18 e 19 giugno e per qualsiasi informazione vi lascio qui i recapiti. Ho terminato, grazie.
Thank you. Dr. Bennett. Nasal cutaneous fistula.
Good afternoon, everyone. Thank you, Luigi, for organizing an excellent meeting and to the organizing committee. My name is Salometa. I come from Philadelphia, and I'm going to show you a novel technique for nasal cutaneous fistula repair. I have no financial interest to disclose. So the causes of nasal cutaneous fistulas of the medial canthus can come from extensive sinonasal reconstruction, for malignancies, patients who have a history of chemotherapy, radiation side effects, orbital exoneration, endoscopic DCR, and Jones tube DCRs. They can be surgically challenging, require multiple surgeries, and they have high rates of recurrence. There are many types of repairs that have been that we've done in the past and continue to do, including paramedian forehead flaps, glabellar flaps, skin grafts, forehead flaps, and staged procedures with pericranial flaps and silicone prostheses when this doesn't work. But these come with challenges. They are often associated with high rates of recurrence and need for repeat surgeries, often within months. They will recur, and with prostheses, there can be related irritation as well. So today I'm going to demonstrate a simple yet effective alternative technique for the closure of these medial canthal nasal cutaneous fistula that I've used to help close. I had a few patients that were referred for fistula after DCR. None of these patients had a history of poor wound healing. One had a history of subperiosteal abscess that was also drained prior to her DCR with a modified Lynch incision. The first two patients had a history of Jones tube DCRs 2 years prior to the presentation of the fistula, and one had a DCR. Two also had previous attempted techniques to close the fistula. So here's an example of one of the patients that I used this technique on. You can see the wound defect there and the fistula inferiorly. The technique is quite simple. Actually, you take vicryl mesh and I place it at the apex of the fistula. Here's a schematic of that. And then I advance the subcutaneous tissue over the vicryl mesh and secure it. And then I place cyanoacrylate glue and I at the fistulous tract over this vicryl mesh. And I don't manipulate the tissue for 2 minutes. And here we can see the patient, 18 months follow-up, no recurrence, and even years later, all 3 patients have not recurred with their fistula. So what makes this technique work? Well, cyanoacrylates have been used for many, many, many years for topical skin closure. They're a monomer that polymerizes when it comes into contact with hydrogen ions. Basically, when it comes into contact with blood or water, it creates a really tight closure. And they have a very strong tensile strength. So the fresh wound edges and the scarification of the wound edge will then create this new granulation tissue, and the tensile strength of the cyanoacrylate glue helps hold this all together. So I hope I've shown you an alternative technique with cyanoacrylate glue and vicryl mesh that can be used as a scaffold, to be used as a simple alternative technique for the closure of nasal cutaneous fistulas. Thank you so much.
Thank you so much. Dr. Estrada, 4 eyelid ectropion due to.
Here. It's my presentation, please. Yeah. Well, good afternoon, everyone. First of all, thank you for the opportunity. It's more than an honor for me to be here. In this opportunity, I'm going to talk about four-eyelid ectropion secondary 2. This is a case of a 52-year-old man who came in 2011. He was complaining about four-eyelid ectropion. He had a history of lamellar ichthyosis since birth with ectropion since 1997, which remained untreated at that time. The ophthalmic examination was normal, the visual acuity was 20/20, the ocular movements were normal, and he had a positive bell phenomenon. We only could see a low decreasivity and elasticity of the four eyelids. Unfortunately, I don't have a picture at that time, but we decided to harvest full skin grafts that were harvested from the forearm. We first tried to harvest skin from donors, but he didn't have any relatives or siblings or parents or children who could donate him some skin, so we decided to take the graft from the forearm. Here you can see some pictures of the surgery. Those are the grafts, and this is the immediately post-op. He had a favorable postoperative course, but unfortunately the patient disappeared for 12 years. And he came back in 2024 complaining again of four-eyelid ectropion. This time he wanted to go under cataract surgery, so we decided to make consultations with dermatology. Prior to surgery, we did 3 applications of 2% hyaluronic acid every 3 weeks to soften and improve the skin quality. There you can see some pictures, and after that we did a bilateral torso strip with retroocular skin graft. It was really hard to lose the skin because all the skin was affected. And this picture was taken last week. So to put this patient into a context, the lamellar ichthyosis is a subtype of autosomal recessive congenital ichthyosis that is characterized by abnormal keratinization and hyperkeratosis. The most common ocular manifestation is the cicatricial ectropion, as in our patient, that can lead to lagophthalmos, exposure keratopathy, with the risk, of course, of corneal ulceration, perforation, and infections. The management can be conservative with the focus on lubrication, but also topical and systemic retinoids. And the surgical management can be full-thickness skin grafts, alternative graft sources associated with lateral tarsal strip procedures. But what are the challenges with this patient? First of all, the severe involvement of the four eyelids. We have limited healthy donor skin because of his general condition. We still have pending the upper eyelid correction, and of course the risk of recurrence and the need of a future surgery because our patient still has 65 years. So that was all, and thank you very much for having me, and I'm open for any questions.
Dr. Matash with an eyelid surprise. Not present. Dr. Levy, present. Moving along. Dr. Dulenberg von Faber-Bisson. Management of lacrimal diverticulitis.
Buongiorno. I will talk about lacrimal diverticulum. That it's a notch pouch in front of the lacrimal system they can communicate each other or not, if some kind of inflammation or engorgement of the venous plexus closes the passage between them. It can be asymptomatic or not, with epiphora, ocular discharge, swelling, infection that we call diverticulitis, or even presented as a silent mass besides the lacrimal system, and then can compress the system and cause some epiphora. Let me show you 4 special cases. The first one is a 9-month baby girl that was referred to me after a probing and then an intubation without solving the skin infection in the fistula. I performed an intraoperative dacrocystography, and you can see a very narrow lacrimal system, and after I injected through the fistula the contrast, I could find an isolated diverticulum. Here you can see the endonasal dacrocystorhinostomy with a marsupialization of the diverticulum. The probing is coming from the fistula until this cavity that is the diverticulum, and the other cavity is the opening of the lacrimal sac. The baby is well since then. And now the second case, we have a 5-year-old girl with a normal lacrimal system, 2 crises of diverticulitis, and after the clinical treatment, she has this silent mass that slightly moves with the skin near the lacrimal sac. Just clinical treatment since then. Here you can see the CT scan showing the position and the size as well in the ultrasound of this diverticulum. Third case, diverticulum associated with dacrocystocele. After an agudization, she had a spontaneous cure. Third case 4, 5 crises of diverticulitis, and she has an obstruction of the nasolacrimal duct. I performed an external DCR and extirpation of the diverticulum, and she's very satisfied since then. Take-home methods. If you have a diverticulum asymptomatic, you can just watch and wait. But if you have infection, you have to remove the diverticulum or marsupialization in an endonasal procedure associated or not to a DCR. Always think about diverticulum in atypical infections near the lacrimal sac. Thank you a lot.
Thank you. Dr. Del Bosque Lopez, the most complex corner of the aisle.
Thank you. Okay. Good evening, everyone. My name is Regina del Bosque. I'm a resident of ophthalmology in Mexico City, in the Conde de Valenciana, and today I'm going to talk about the most complex corner of the eye. Thank you very much for having me. So thanks to all the oculoplastic departments at my hospital. So this is the case of a 52-year-old male who presented in 2023 a trauma by a firearm in the right eye. Then he consequently had a orbital fracture and also a right evisceration.
He was treated externally with mesh on the floor and also with maxillofacial screws. After that, in 2024, he went through removal mesh due to the infection. And 8 months later, he refers inflammatory symptoms of the medial canthus and also mucohyaline secretion. He has no other medical history that is relevant for the case. So this is the clinical photo of him, where we can see in the middle, in the lower eyelids, the 3 cysts that he has, and also we can see a really important dystopia from the right canthus. So here's another photo at 45 degrees. We can see the 3 cysts and the really important dystopia. So about the left eye, everything within normal limits. So here we have the CT scan. So we can see the osteosynthesis material, and also we can see the loss of continuity of the floor and also the lateral wall. Here we can see the 2 cysts that he has on his right cavity. Here we can see the all-wall medial fracture that he had. And here we can see also the 2 cysts, and one seems to be beloved, as you can see in the bottom. Also we have the cyst and seems to be really associated with the bone, and the facial massive was not trapped. Here's a 3D reconstruction of the osteosynthesis material. So, the challenges to be addressed in this patient is that he has suppurative eyelid cyst, he has a medial canthal dystopia, and he also refers really discomfort when with the prosthesis placement. So the surgical plan with him was a right DCR, a medial canthal reconstruction with a CY-plasty, and also the excision of the lower eyelid cysts, as you can see in the image. So, a 2 centimeter incision was made, then the sac, lacrimal sac was exposed, then we did a osteotomy with Curry's and Rogers, then the inferior canaliculus was well cannulated, and then we extended the Y incision in order to excise the 3 cysts that he had. Then we did the medial canthal fixation with a 5-0 Berlin suture, and we anchored it to the posterior lacrimal crest, and then we used a 21 gauge needle in order to do that fixation. We closed with a 6-0 bicreal suture, and then we end the CY-plasty, and we put like a Penrose-like drainage, as you can see. So here's the post-op at day 1. That's the pictures with his prosthesis. Here's the post-operative week 1, the post-op month 1, the post-op month 3, and here we have a timeline of our patient, day 1, week 1, month 3, and he's really happy. Now he's waiting for the new prosthesis to fit in his right cavity. And well, the conclusions: we have to use the deep vector when incurring the middle ridge, we have to anticipate the needs of our procedures, and we have to have a plan that is alternative to these surgical approaches. These are my reference, and thank you very much for having me.
Thank you. Okay, Dr. Matash, we're back in order. Eyelid Sopranos.
Okay, thank you very much. It's a pleasure to be here. Thanks to Luigi for the invitation. Aspettiamo Roberto un attimo. So I will talk about the case that it's called eyelid surprise, and it was a really surprise at the time that we have the result of the exam. So this is our patient, 50 years old, male, with the left eyelid ptosis since 2 years, healthy, with a history of smoking for 20 years, and surgery of lipoma in the thorax. And at the time, he presented with a painless mass, as you see here, increasing since last year, leading to blepharoptosis. The visual acuity was normal, holding up the eyelid, 2020, and the fundus was normal. So, at the MRI, we have this lesion, round lesion, hypointense in T1, and hyperintense in T2, as we see here. Actually, I have an echography in my office, and we did this at the time before the surgery, and we can see an heterogeneous tissue formation with hypoechoic areas and areas with mixed vascularization in Doppler. So we go to surgery without knowing what could be at the time. This is our patient. So the surgical plan was to remove the tumor and obviously to correct the ptosis. We perform a skin crease approach. We cut the auricularis to get to the septum, and then we can see the surface, the anterior surface of the tumor, and below we can identify the elevator aponeuroses. It had the aspect of a cavernous hemangioma, so we decided and continue with the blunt dissection. We identify the pedicle attached with a hook, a strabismus hook. We pull apart the tumor from the pedicle, and then we are able to remove completely, as we see here. That's the mass, had around 2 centimeters. So we correct the eyelid ptosis with the one stitch in the elevator aponeurosis, one single stitch. So we close the skin with single stitch skin aponeurosis skin, and that's our patient 20 days after. So when we receive the pathology about a month or 20 days after, that's our surprise. It's a cavernous venous malformation. And as we know, a cavernous venous malformation, known also as cavernous hemangioma, is a relatively frequent benign tumor of the orbit. Already not a tumor at all, but is considered vascular malformation, low flow, and non-distensible. And Rudman described all this location of the cavernous hemangioma, and it could be the one picture of the left that came from the conjunctiva and the vascularization from the anterior surface. So, MRI and echography helps to approach the diagnosis, and as in all these cases, the surgery is relevant. Having recognized the vascular isolation, some authors recommend to puncture the lesion, shrinking the mass by examination, and then we can remove the lesion without marginotomy or lateral orbitotomy in the orbit, not in our case. And there are few cases in the eyelid. Thank you very much.
Thank you. Dr. Velasco-Levy. Life works in 3D.
So Luigi, thank you very much for the invitation. And well, we have to remember that life works on 3D. Could you play to the video, please? So this is a three-dimensional dynamic reconstruction for paralytic ectropion and secondary lag of thalamus. Play in the video, please. Okay, so paralytic lower eyelid malposition remains one of the most challenging conditions in oculoplastic surgery. Its complexity lies in a multifactorial pathophysiology involving loss of auricular stone, vertical instability, and disruption of eyelid globe position. Traditional approaches often addresses these components in isolation, frequently resulting in suboptimal or short-lived outcomes. This is a reconstructive approach to restore functional eyelid balance by addressing all vector forces simultaneously. A lateral cantotomy with partial cantolysis is first performed using a Colorado needle or Westcott scissors. Traction sutures are then placed to avert lower eyelid and improve surgical exposure. A transconjunctival incision is made approximately 2 millimeters below the inferior tarsal border, followed by layered dissection through the conjunctiva septum, and lower eyelid retractors. An acellular dermix matrix graft is then placed at posterior lamellar spacer and secured from medial to lateral using a running 6-0 vicryl suture extending laterally to the edge of the tarsus. Further dissection is performed to release the lower eyelid up to the level of the lateral canthotomy, allowing complete mobilization. Attention is then directed to the upper eyelid. A traction suture is placed, and a modified tau flap is designed using a 15 blade, incorporating a segment of the levator aponeurosis and Mueller muscle. Careful superior dissection is essential to fully release the modified tau flap and ensure attention for free construct. The median portion of the flap is then sutured with the spacer using a continuous 5-0 vicryl suture in an inferior to superior direction. The lateral portion is then anchored to the residual lateral canthal tendon and periosteum, also using a running suture. The flap is then lateralized and anchored to the lateral canthal tendon and periosteum, functioning as a dynamic tarsal strip, with an oblique and superior vector to the eyelid that enhances the closure. The technique described here differs in that it combines structural correction with redistribution of active muscular forces by integrating posterior lamellar expansion, levator-driven dynamic support, and lamellar anterior reinforcement. The reconstruction addresses all relevant vectors simultaneously. Rather than acting as an independent components, these elements function together to restore eyelid stability across the vertical, horizontal, and dynamic axis. This technique is not limited to secondary or cicatricial ectropion, but may also be extended to the management of eyelid retraction and lengophthalmos of diverse etiologies. Patients with facial nerve palsy appear to derive the greatest benefits, as the incorporation of the levator complex contributes to improve eyelid closure, dynamics, and increased tonic support through a favorable vertical vector. The principal modification of this originally described technique, tau flap, is the addition of the lateral canthotomy, allowing for flap lateralization without reducing the palpebral fissure, thereby achieving a more natural aesthetic outcome. The addition of a posterior lamellar spacer enhances the vertical vector and increases the eyelid globe apposition and contact surface, contributing to improved structural stability. Furthermore, incorporation of Mueller muscle and the levator aponeurosis enhances lower eyelid closure force both in primary gaze and up gaze. This results in a more favorable lateral canthal configuration, characterized by a dynamic, positive, and V-shaped angle. 3 months post-op confirms stable vector alignment and excellent aesthetic outcomes. Thank you very much.
Thank you. Dr. Dominguez Delgado, botulism toxin, placed intradermal.
Good afternoon, everyone. For everyone who's here, still here, we're going to start with another article, and the author is clear. There are no conflicts of interest also. For beginning, facial pores anatomically consist in pill sebaceous unit with sizes from 40 to 80 microns, reaching up to 150 when there is dilation to the increased sebum production. All the sebaceous glands have nicotinamide receptors for acetylcholine, and the microtoxin technique that involves the application of the dilution of botulinum toxin type A is something that could help because the differentiation of the sebocyte is altered by the inhibition of the acetylcholine release. That's why our purpose in this work was to evaluate the effectiveness of intradermal botulinum microtoxin as a treatment for seborrhea and dilated pores in periocular skin. As methods in this prospective, longitudinal, and comparative study, our inclusion criteria were aged between 18 to 35 years old, both genders, and diagnosed with oily skin or having dilated facial pores. Exclusion criteria: incomplete questionnaires, being pregnant or breastfeeding, having neuromuscular diseases, or also going to a steroid treatment 6 months before. Well, the microtoxin was prepared with a dilution of 500 units of botulinum toxin type A in 7 milliliters of saline solution. The application area was cleaned with antiseptic, and facial blotting paper was placed to 10 minutes in both part of the face for measuring the oiliness. The facial pore measurements, we use the ocular keratograph for having a little bit more number, very specific number. Face Q&SQ questionnaires were conducted, and topical anesthesia was applied. 5 points were marked in each side of the face, injecting 3 units of microtoxin at 45 degrees until a whitish papule is formed. As you can see in this part of the face, there are the 5 points with a whitish, and also the ocular keratograph that help us to, with caliper and photograph camera, measure more specific each pore. A total of 30 subjects were included, 21 were male and 9 female. The sebum production was measured in a semi-quantitative way, millimeters square, using the blotting paper. A significant decrease in skin oiliness measure was observed 6 weeks after the initial application of microtoxin, as you can see in the box plot graphics, and also in table number 1 with statistically significant results. The facial pore measurement, as I told before, was performed with ocular keratograph 5M, and significant decrease in the pores was also observed with statistically significant, beginning with 500 microns before application of microtoxin, and post-treatment 6 weeks, 200 microns in average. The self-perception skin quality measured with face Q scale was also significant, and very good improvement from 50 points to 70 points, and you can see it in this box plot. Less points were a little bit more significant. And finally, the SASQ questionnaire, who evaluated skin quality, also reflected a decrease in points, who was statistically significant and good for our patients. Finally, the microtoxin technique reduces the cell production with a high level of satisfaction, and is a new kind of innovative treatment for these conditions. The standardization of the technique is necessary. That's why we have to increase our sample to have a little bit more reliability. That's all. Thank you very, very much.
Thank you. We're running ahead of schedule, which is great. But we have some time for any questions or comments for our speakers. Yes, sir.
This is just an observation, Dr. Meredith. The survey that you showed, the mucosal graft, was published in France in 1887. It's called the Milligan procedure, very popular in Brazil. For the low eyelid, works very well, but for trachoma, I'm going to say, if you don't do a lid margin rotation, because trachoma is a cicatricial entropial with tarsal deformity. So most people that work with trachoma, I think 100%, they don't do that. They do lid margin rotation. But for the low eyelid, it's a very, very classic procedure that in Brazil, they call it the Milligan procedure. Is very popular.
I couldn't more than disagree with you. My experience with trachoma is trachoma that's no longer active. Are you speaking of trachoma that's active?
No, trachoma was very popular in Brazil, very common a long time ago, and I lived 2 years in Saudi Arabia. We did trachoma surgery almost every week. I mean, if you don't do a lid margin rotation, because trachoma, the inactive form of trachoma, you have tarsal scars. So you have to do a lid margin rotation. It's not just tracheitis. There is no such thing as tracheitis and trachoma without entropy. The World Health Organization uses the term trachoma tracheitis, but this is a very bad designation, because what you have in the upper eyelid intracoma is a cicatricial entropion with scars on the tarsus. So you have to divide the tarsus and do a lid margin rotation. For the lower eyelid, this procedure that was published in 1887 it's okay. It's okay. I mean, it works well.
Did you have a comment?
Volevo fare un commento in italiano, sono sicura che mi capirete. Quando pensiamo all'ectropion o entropion nelle forme gravi, dobbiamo sempre tenere conto dell'elevator, perché quando pensiamo all'elevatore noi pensiamo spesso alla ptosi, invece nelle forme di ectropion l'elevatore è molto importante e secondo me quando abbiamo un entropion della palpebra superiore lo dobbiamo sempre coinvolgere, perché l'aponevrosi che va alla cute determina una fisiologica eversione delle ciglia. Se noi facciamo cute e orbicolare al tarso abbiamo solo una stabilizzazione e potenziamo la forza della lamella posteriore. Se ancoriamo anche l'elevatore rispettiamo la puleggia fisiologica che l'elevatore determina sulla cute, e in estetica chi fa l'estetica vede che ha una fisiologica eversione delle ciglia indotta dall'aponevrosi dell'elevatore. L'altra cosa importante è sull'ittiosi. Nell'ittiosi i pazienti che hanno l'ectropion ce l'hanno in tarda età, non in giovane età, per cui in questa età la malattia è andata avanti e spesso non abbiamo cute a disposizione per fare innesti che spesso non si possono fare. In questo caso io ho fatto diversi casi e con risultato ottimo facendo un lateral tarsal strip e facendo una resezione totale del retrattore della palpebra inferiore per via transcongiuntivale e mettendo poi per 48 ore una sutura di Frost alla fronte, in modo che la palpebra senza toccare la cute abbia gli stimoli per stare in posizione corretta. Vi assicuro che è una tecnica che dà un ottimo risultato senza lavorare sulla cute.
Yes. I just want to briefly say what the colleague Dr. Jacobin said. And the first point she's just saying the role of the elevator into your kind of surgery, especially of course in the upper eyelid. How would you take into account the levator function and the aponeurosis insertion when you go ahead and do your surgery that you demonstrated earlier? If you think it has any role, the levator function or the levator aponeurosis. I think that was the question. If you think that in the surgery that you showed us, if the levator function and the aponeurosis insertion you would take into account and you would treat differently in each case depending if it was a poor levator function or better levator function. Something, yeah.
In cases of trichiasis with the upper eyelid?
Yes,
okay. Well, in the cases I showed you, and I suspect that our differences are related to the degree of scarring from glaucoma. As you know that, it's repeated chlamydial infections, and so perhaps my patient population escaped as many infections as your patient populations might experience, because mine responded quite well to lid margin rotation and graft insertion, did not recur. But again, I suspect that your patients had more scarring that my rotation might not have worked for them. And again, my patients, which are probably relatively mild, had no effect on their levator aponeurosis.
Yeah. The other point the colleague was saying is about patients with ichthyosis. Should we do because they present late in life and they don't have skin to take, that she would treat with lactose strip and release of the inferior retractors and with a frost suture. That was, I think, a comment that she was making there.
Well, you know, I mean, I'm all for releasing the inferior limb retractors when it's a factor. In these patients, I don't think it was a factor or necessary. Perhaps in more extreme cases it would be.
I have a question for the colleague who presented about the lacrimal gland prolapse, because he mentioned he wouldn't use the Vicryl anymore. Is that because you would see recurrences and now you use Prolene instead?
No, I believe with Vicryl I had some more inflammation. As I mentioned, this patient had more inflammation, more weeks of inflammation. I believe that with a nylon or a Prolene, they can have a longer lasting and less inflammation.
I mean, don't you think that maybe it's a mild inflammatory response that we do get from Vicryl might help to create a barrier to keep the lacrimal gland, the palpebral lobe of the lacrimal gland up, or does it make a difference?
Not to me. I don't think it makes a difference. I don't know, for you, do you use Vicryl?
Yeah, because I use routinely, well, not many cases that we do, fortunately, but it's only aesthetics, really.
I'm older than you, and I'm going to tell you something. I stopped doing Vicryl and Mercilin. I tried everything for tarsal strips. Now I'm doing Prolene or nylon, just because of I want to sleep better. So I'm not sure if that really helps for longer lasting action. And I also changed to nylon for monofilament.
Monofilament.
Yeah, I believe that you can have less inflammation there. But you're right. Maybe probably if you have inflammation in that area, you can have better result. I don't know. Anyone here uses a non-monofilament suture to fix the...
Mercilene also.
Mercilene? Yeah. No granulomas?
Sometimes.
Yeah, I'm afraid of granulomas. I learned to use Mercilene for tarsal strips.
Tarsal strips.
Yeah. So I'm far from Mercilene.
Yeah, I agree.
Now we can make
granuloma is there with Mercilene. Prolene, no inflammation.
Prolene is very good. Yeah. Sometimes I do one suture, and sometimes I need to do two sutures.
Yeah. And you were mentioning also about the possibility of dry and non-dry, because probably the lacrimal gland comes into play with the reflex tearing as opposed to basal secretion. So probably...
Yeah, I mean, there are no reports regarding dry eye. And I talked with Christina yesterday or the day before, and I believe that we as oculoplastics should get more involved with dry eye. I mean, nobody, no cataract surgeons, no cornea, nobody sees more dry eye or ocular surface than us.
Of course.
We pemphigoids, entropions, ptosis, lab-ophthalmos, everything has to do with the eye.
I agree. Yeah.
So I believe that that we should be more focused on what's happening with the ocular surface.
For us, it's either too dry or too wet.
Absolutely. Yeah. And even if they cry, we use eye drops.
Of course.
Thank you. I want to ask you something. How often do you biopsy to make a diagnosis of pemphigoid?
The diagnosis on biopsy is about, in my experience, 30 to 40% effective. Now, I've tried to refine that. Dr. Foster is kind of the godfather of OCP in the United States. And I had my lab call his lab, where he had a much higher percentage of positive results on biopsy. But even trying to emulate Dr. Foster's lab techniques, we still were at 30 to 40%. So,
I ask because we see a lot of pemphigoid cases, and I always tell my residents and fellows, if you see an eyelash that is going into the eye, that's not normal. if you see an entropion, you have to be sure that it's not a cicatricial entropion. And I have a lot of referrals from colleagues of mine that send me patients for entropion repair, thinking that it is an involutional case, and if you touch those cases, everything burns out. So you have to be very sure that it's not a cicatricial entropion there. So how often do you rely on the biopsy, or you just, if it's a dog, if it grows like a dog, then it's a dog?
Well, you know, usually you're going to find four-lid scarring in these patients. I have been fooled a couple of times where only one side was involved early on, and then the other side later became involved. But it's a clinical diagnosis. It's difficult to pathologically confirm this. And, you know, we have rheumatologists and dermatologists who help us in the medical management of these patients. And then, fortunately, we have a good enough relationship that we say this patient needs medical therapy. And so we treat patients medically even with negative biopsies or without biopsies.
Maybe one more comment. Just for young people, always, we're ophthalmologists, always review the conjunctiva, everted tarsus. I have seen one of the worst cases that I've seen is from a colleague, a very good friend of mine. He did it was a perfect phaco surgery, perfect, 2020. But the patient had pemphigoid, so everything went bad. So please check the tarsus, check the conjunctiva. Abnormal lashes, some scar in the tarsus or conjunctiva, send it to someone else. Sí.
I just have a small comment about the pemphigoid, cicatricial pemphigoid, and you know, I'm Ed Holland, which is a cornea surgeon and works a lot with pemphigoid and all the reconstruction of eye surface. He works in Cincinnati, so he had a bunch of many cases, and he thinks that when he asked the oculoplastics doctors to take a biopsy for pemphigoid, for confirming pemphigoid, he thinks that taking the biopsy from the cul-de-sac or from the scarring area on the tarsal conjunctiva is not the best example, and he always recommends to take the biopsy from the bulbar conjunctiva, not necessarily something that looks pathologically in the macro, but that's helps a little bit better to get more accurate results on your biopsy.
And if you biopsy where there's scarring, quite often it's burned out at that location. Any other questions?
I have a comment for Dr. Barcells about DCR and tumors. I don't know how many people here request a CT scan before the surgery, routinely. I do. And for me it's important to stress the concept performing the DCR, that it is important, open before the sac and then to perform the osteotomy. I know that there are people that before open the bone, and that this is conceptually not correct, especially in case of a rare case of tumor. Te felicito por la presentación.
So I agree with you. I think we don't have an accurate answer, because if we do like CT scan in all of our patients, we probably will be overdoing exams and doing more radiation and raising the cost of treating our patients. But I mean, you don't want to miss anything. In my practice, what I do is I only ask for CT scan in all the cases that gets anything out of ordinary. So if it's a young patient, if the epiphora pattern is not normal, in those cases I definitely ask, or if I see that there is a mass or something. In the other cases, I don't regularly do the biopsy, the CT scan or image, any kind of images. And I agree what you say, and I think open the sac before doing the osteotomy helps to maybe realize if the sac looks or not normal, but it also requires it relies on how macroscopically the sac will be, and I don't know if really that's the only, it helps, but it might look normal. Actually, Dr. Badala just left, but he was telling me about his case. It looked normal, and then it ended up having a tumor. So I don't know exactly if that's the key point. And I talked to other ENT doctors, and they say that they don't think that we are reducing the risk of a tumor to go into the nose if we don't do the osteotomy. So they don't feel like we're kind of avoiding anything before. So the question, and I don't know, Bob is not here now, but I don't know if this is, there is not an answer, but I mean, how expensive it is to go ahead and biopsy everybody or not, I don't have the answer, but I don't want to miss anyone.
Actually, I had only one in my short life, lacrimal sac lymphoma, during this year, I saw the CT before, and it was not useful really. I opened the sac and I suspected something wrong, and I performed the biopsy. I stopped the surgery, and after the result and the oncologist consultation, we performed the surgery this year. You have reason. I agree with you.
Any other questions, comments?
I want to ask Michelle, we do the same technique as you do, and te lo digo en español. Hacemos muy parecido, igualito, tenemos un par de publicaciones. La pregunta es, vi que tu injerto es más grueso, nosotros tomamos injertos más delgaditos, y normalmente lo hacemos muy pegado al borde de la ceja, arriba o abajo, para que no quede la incisión a la mitad de la ceja. ¿Has notado cambios en eso?
No, la incisión la hago justamente en el centro porque, según mi opinión, se ve menos, pero sobre todo es para conseguir la buena orientación de las pestañas. Entonces, lo ideal, que no lo ves en el vídeo, se suele coger para un párpado superior derecho, se coge de la ceja izquierda, porque la orientación de las pestañas está mejor. Y lo más importante es la sutura del injerto, haciendo una separación de la lámina anterior y de la lámina posterior, dejando una eversión con una trastorafia de una semana, porque la complicación de esta cirugía es que tengamos una dosis de las pestañas que están injertadas. Y cierro con mi problema.
Anyone else? Just a comment. Sadly and gladly, war has given us several therapies. A pathologist examining the effect of mustard gas on rats and mice in World War II saw that it wiped out the lymphatic system and it led to the evolution of chemotherapy. I was a young resident, and Dr. Momini was chairman of the Wilmer at Johns Hopkins and a visiting professor, and somebody in the audience said, Dr. Momini invented Botox. And I raised my hand and I said, Dr. Momini, did you invent Botox? And he told this story from the horse's mouth, so to speak. He said that when World War II developed, he had just graduated from his residency and he enlisted in the Navy. And the Navy said, you're a physician. In World War I, chemicals were used in the battlefield, and we're concerned about the use of chemicals in the battlefield in World War II. And Dr. Momini, we're going to put you in a unit to come up with tests for the presence of chemicals in the battlefield. Dr. Momini said, you know, being an ophthalmologist and knowing that the eye had sympathetic, autonomic, all sorts of responses in the nervous system, he said, I thought I could take animals out into the field and perhaps put chemicals around their eyes, see the reaction. And I got to thinking about botulism toxin paralyzing muscle. And so after the war, I challenged a couple of fellows I was training to look into uncrossing eyes with botulism toxin. And as you know, it was Alan Scott that then was his fellow that did get approved oculinum for the treatment of strabismus and blepharospasm in about 1982. But it's an interesting bit of ocular history that, again, I got from the horse's mouth. Luigi, shall we take a break or shall we move forward with the program? Move forward. 10 minutes. Okay. 10-minute break.